and the Vice President of Health Initiatives at the Community Service Society, Elizabeth Benjamin.
Thanks.
Careful.
Yeah. Hi.
Healthcare.
Hi, Ms. Benjamin.
Hi, good afternoon. Thank you for affording me and the Healthcare for All New York campaign an opportunity to testify today. We're really excited about this topic. It's a really interesting topic. I think you all have had a really interesting back and forth, both with the state and with the health plans. And I think we'd like to start out with saying that we think that the sort of issue of coverage mandates may be a little overstated in terms of the concern. You know, there are lots of things that aren't considered. Did you get a copy of my written testimony? I'm skipping the whole statutory framework. I feel like we've really gone through that already, you know. So
right.
if you're following along with me, I won't be reading from my testimony because in deference to my colleagues having patience and time issues. So I'm starting on page 3, just to let you know where I'm going. Okay, so there's lots of things that we don't think are actually considered mandate per se. So changes in enrollment rules, changes in choices of provider rules, none of those things we would consider to be a benefit mandate. In addition, we think that there are some benefits that the legislature adopted prior to 2011 that contemplated that there would be a change in the standard of care. For example, fertility treatments, I'm at the top of page 4. And we think that also would not be a benefit if we were to change our, questions, our state policy around fertility treatment. We think that might also evade, the state underwriting the cost for it. I think moving down, there are certain things that are just sort of standards of care that have changed over time. So, for example, we think this, again, would not be an additional benefit mandate that the state would have to pay for. For example, recently the Department of Financial Services issued guidance saying that sex reassignment surgery is surgery. It's part of the essential benefits package. It's not cosmetic. This is not a state benefit mandate. Another example of something that we wouldn't consider a state benefit mandate, for example, is compliance with federal law. So I think there was a back and forth about the drug tiering that, for example, patients with HIV, patients with MS, patients with cancer have to have at least one form of drug, available at all the tiers level for them. And that's inconsistent with the federal law. That's not something that the state should have to ever underwrite. So then, what about future mandates? There may be some. For example, there's certain things are not in our current essential health benefits Oxford plan. Dental benefits. There's a huge demand for, we talk to consumers every day, there's a huge demand to include dental benefits. Some people want acupuncture, some people want, massage therapy, chiropractic. I mean, there's lots of things that people might be interested in. I think those would have to be paid for by the state, short of Chairman Cahill's 1332 waiver idea. But I think, and I think the state will have to think carefully about whether we want to pay for that. But there's other things that really are going to be changing that we have to. I guess our position is this: the ACA did not set the standard, the medical standards of care in stone in 2011. That medical technology is changing all the time. Gene therapy is a really good example. Blood markers for diagnostic technology. Those things we're going to have to figure out a way to either include them in the essential benefits package or decide as a state to pay for them. So what would be the process for that? Well, the state is going to have to move forward. Our state policymakers are going to have to move forward and evaluate each one of these possible mandates. We think that the federal law requires sort of squarely sets the responsibility for engaging in this evaluation with the Department of Financial Services, and we think that would be sort of it's part of the sort of rate-setting actuarial conversation that happens between the state and the health plans with public comment. So that's one process where it's going to come, be sort of hashed out. I think if the state does move forward and decides to adopt new coverage mandates, it is Healthcare for All New York's strong position that it shouldn't be borne just by those folks that are in the individual market through the exchange. That this should be something that is, either funded through the general fund or HICRA or a broad-based tax. Another way that that's our strong position, is that any prospective mandates that have to be borne as a cost should be funded broadly. And then the second thing that we wanted to really leave with you all is that the federal statute contemplates the payments for these mandates, how the state should be paying for them. It can be done in one of two ways. You can pay consumers directly, or you can pay the health plans directly for their, because their health insurance costs will go up. And to the extent it's going up by the price of the state mandate that's imposed by that state mandate, we feel very strongly that instead of paying the carriers through having the carriers sort of administrate that cost, that we should do the payments directly to consumers, either through, if they're on APT, advanced premium tax credits through the exchange, we think that's one mechanism to do it. If they're paying full price, then it can be done through the state tax process. So that's just another thing we wanted to leave with you. And then finally, I think a lot of the whole conversation could be avoided on some level if the state just determined to adopt a different benchmark, a different essential health benefits plan. It's been Healthcare for All New York's strong position for every time the question of the essential health benefits plan coming up. We've suggested adopting the Empire plan as the benchmark plan, not the Oxford small group product. Our desire for that was turned down both times, however, by the state, who I think, as Donna and Troy were discussing, really wanted to balance affordability with the sort of the breadth of the benefit package, if you will. But I think if we did go for the Empire plan, that state government and city government, that government officials uses their own health insurance, I think we would have an easier time sort of wrestling with these mandate issues. There's one last thing I wanted to talk about. There was a whole back and forth about why costs went down by 53% when we rolled out the exchange. And I think I would just like to say that the plans, when they were setting their prices, anticipating their prices for the first year of the Affordable Care Act, believed and were given much data by their own actuaries, as well as the state's, experts that brought in a lot of stuff, that there would be a very big enrollment, and that we would see an enrollment from that 13 or 19,000 people in the individual market to hundreds and hundreds of thousands of people joining. And the reason why people join was, and I can tell you this because I talk to people every single day, and the reason why prices went down is the dual impact of having subsidies as well as the individual mandate, as Chairman Gottfried mentioned. But also, I don't think we should estimate the power of those subsidies. The vast majority of people that move through the individual marketplace at this point are subsidized, and that's what really drove this incredible surge of enrollment, was the ability that suddenly health insurance was affordable. And sort of as evidence to this, I would like to point that the Platinum plan in the marketplace is essentially equivalent to what the old individual marketplace preset plan design was. And even with the most expensive individual Platinum product, it was $700, which was far shorter of the $1,600 that United, or $1,200 that United was charging on a monthly basis in the old world. So I just think it's the impact of what really drove enrollment was the individual mandate and the subsidies.
Thank you. Just to go over a few pieces of your testimony, you suggested that the state pick a different benchmark plan, but we heard Ms. Frescatore say the horse is out of the barn on that one.
Yeah, I mean, we feel there'll be another opportunity.
I'm sorry, say again?
We believe there's another opportunity coming up. We think there'll be another opportunity to come up to set.
What makes you think that?
I mean, it seems like it happens pretty regularly with the federal government, that they come back. So
it happened once, and it was part of the original act, and the Congress has not stepped up since that time. What makes you think?
But can't the state do it? Couldn't the state legislature mandate it?
Could the state legislature mandate that the federal government accept the new essential health benefits plan?
Forgive me, I misspoke. Could the state say to the department that they should adopt a different essential health benefits plan?
My
And could they
understanding,
submit that to the feds?
my understanding is from Ms. Frescator and Mr. Ochsner's testimony that a decision had to be made and a submission had to be made to the federal government, and that no provision has been made to reopen that decision. So I don't understand where
Okay.
the state legislature would get the authority.
We did not. It's not our belief that it's a closed door. That we believe that states can go back and ask for a new benchmark, a new essential health benefits package.
What do you base that on?
That's our understanding. I mean, if we're wrong, we can.
Of the law?
Yes, that's our understanding of just the regulatory process between. I mean, I don't think, for example, it just seems to me. Well, I guess I
Let
think
me
that
just interrupt you for a minute,
sure.
because I think that makes sense, right?
I mean, I just think that's a regulatory
I think-
give and take between the feds and the states.
I think that makes sense.
Yeah.
I don't think the current Congress makes sense. And if your estimation that this is what is possible is based upon what it should be because it makes sense, I think there's a false premise here that the Congress is going to do something that makes sense.
It's my understanding that this is actually a regulatory discussion
Okay.
between HHS and the state government. So I thought,
If you
and I
can
could be
cite,
wrong. I
if you
will-
can cite any authority, I'd appreciate if you
Sure.
send it to us, because that's important for us. We'll send it back to
Sure.
the first panel of witnesses, and maybe we'll have an opportunity to revisit the question. Let me-
Just on that point, and it's your understanding that if the feds allow New York or all states to choose a new benchmark plan, that would reset the level for whether the state mandate to pay for the benefit kicks in? In other words, it would move the
No, I
this-
think what would be covered, so say my scenario, right? We go for the Empire plan. I think that would be our new, that would be our new benchmark plan, our new AHP, right? But I think if the state then had passed a mandate after that, I don't think that would necessarily be paid for. But I would think that the Empire plan tends to have a more generous benefit package than, for example, the Oxford Small Group, which we currently have.
But if that became the state requirement, would that trigger us having to pay the difference?
I don't believe so.
You don't-
I mean,
Okay.
I really thought this was like a regulatory discussion between
Okay.
HHS and the state. And, forgive me if I'm wrong about that. We will go back and look for guidance. But it seems to me that the state goes back and does do-overs all the time with HHS on certain decisions. I mean, that's not unknown between states and their regulators.
What about the 1332 waiver process?
It's really interesting. I mean, I guess you could do that. I kind of have to agree with my predecessors. I really thought, I guess you could, but I really had always been thinking about 1332 as a way to do Chairman Godfrey's single payer plan, or to do changes in affordability, like as Ms. Frescator was speaking of doing changes to figuring out ways to get around affordability. For example, the very high deductible, from our experience, for people with the standard silver plan, or doing something like that. But perhaps we could, for including dental or something like that. It's an interesting idea.
Okay.
Why not?
In your written testimony that I scanned very quickly while we were sitting here,
That's good. We wrote it really quickly.
that's okay. If I'm interpreting it correctly, what you're indicating as the cost to a plan is different from what I think we've heard talked about so far. We've heard it being discussed in terms of the impact on premium. You break it down a slightly different way. You talk about its impact on the medical loss ratio. Is it your position that the regulatory agencies that are reviewing the cost question should see how it reflects the overall MLR, or is it a benefit by benefit determination?
I'm not sure.
Okay.
I'm not sure. We'll get back to you about that.
I'd appreciate that.
Yeah, that's
Thanks.
also a good question. I thought it was benefit. I actually also thought it was benefit by benefit, but I will check to see.
I was just basing it on what your reference to the MLR.
I didn't really understand that to be what we were
Okay.
saying, but I
John,
will
do you have any-
double check.
Dick, go ahead.
The mode of calculating the cost of a new mandated benefit, we were talking earlier about whether that calculation should take into effect future savings. If you do this now, people will be healthier later, as opposed to savings within a given year, or the cost within a given year. Do you know whether the cost can be calculated as a net cost, in the sense that if you do X, if we mandate that you offer X, yes, that will be expensive, but you will save an equal amount of money because you will no longer have to do Y?
I feel that would be what the actuaries would do. That's part of that given. I mean, from our understanding, it's done. This would essentially be happening through the rate setting process. And traditionally in the rate setting process, those are the kinds of conversations. The actuaries at the plans do their best efforts to anticipate costs. I think as part of, as I understand the way actuaries think, they think about the cost of the expenditure, but they also think of any offsetting costs for savings. And so that's sort of that contemporaneous process. And then I think whatever the plans put forward to the department then reviews, their own actuaries look at it, public comment occurs, and then a sort of a rate pops out at the end, if you will. So I think that is part of the conversation, or at least it should be if it's not, but I really do think it is.
Okay, thank you.
But, my predecessors, testifiers, probably know it more intimately than I do.
Yeah.
Thank you very much.
Are we done?
Thank you.
Okay.
Kevin, walk out.
We will go on.
There you go.
Okay, Dr. Joseph Sellers and Mo Oster. Good afternoon. If you could both identify yourselves for the record and then proceed.
Good afternoon. My name is Dr. Joseph Sellers. I'm an internist and pediatrician with Bassett Healthcare in Cobblestone, New York, and the assistant treasurer of the Medical Society of the State of New York.
Sorry.
Go ahead.
And Mo Oster, Vice President for Legislative and Regulatory Affairs with the Medical Society of the State of New York. Dr. Sellers, however, will be giving the testimony.
All right. Well, thank you. And we do thank you for inviting us to discuss essential health benefits and what should be added to the health care services required by plans offered through the exchange. We welcome your review of these important issues, and we're anxious to hear the committee's perspective, as well as from other groups, as to how we can together address gaps in our health insurance system here in New York. At the same time, it is imperative that the committee review not be limited to which healthcare services should be covered, but also to address the hassles that patients face when they seek to assure their health insurance plans actually provide coverage for the care they need. The increased availability of subsidized health insurance coverage is a positive development for our patients. However, we see that more and more patients are finding themselves underinsured due to inadequate coverage and narrow networks. Exacerbating this problem are the increasing administrative burdens inappropriately delaying needed care. To begin with, physicians across New York have identified many healthcare services that should be routinely received by our patients and should be covered by health insurance companies, but sometimes are not. For example, physicians have called on MISNY to seek legislation to help ensure patients have coverage for testing and treatment for hepatitis C, testing for HIV, both of which are mandated by the state, but we need to have coverage to make those mandates real. Enhanced screening for autism and other developmental disabilities. We have folks who want to go outside the preschool programs and the health department programs to have private screening for developmental disabilities in areas where there may be more expertise available. Attention deficit disorder, hyperactivity, We have concerns that the lowest cost sharing tier should be available when a patient is stabilized on a particular medicine. We have a mandate for reporting to women dense breast tissue in their mammograms, and we really think there should be coverage to have those women to have follow-up care for the dense breast tissue. However, the fact that a service is designated as essential does not guarantee that the patient can easily receive that service or even have coverage for that service. It's important that the insurance we provide patients has real teeth, that they really can get coverage for their care. One big problem is cost sharing. Many patients are surprised that their coverage does not begin until they've already paid thousands of dollars out of pocket. MSNY recently conducted a survey of the physicians in our state, and 21% of the responding physicians reported that a quarter to half of their patients faced deductibles of $2,500 to $5,000, and another 32% of responding physicians reported that up to 10 to 25% of their patients faced deductibles of $2,500 to $5,000. The Kaiser Family Foundation recently reported the average worker has to pay nearly $1,100 deductible, a 67% increase over the past 5 years, and that the average combined deductible for 2016 is $5,765 for bronze plans and $3,064 for silver plans. And I can tell you, in my practice in Schoharie County, 32 miles south and west of here, that I see patients every day who I recommend a screening, a treatment, a medication for, but they decline to follow my advice because of the costs associated with out-of-pocket deductibles and copays. Another problem that we are concerned about is inadequate networks. Many physicians report network insurers offer to patients are increasingly inadequate. Nearly 14% of our responding physicians reported that their participation contracts with an insurer was not renewed in the last 3 years. And another 22% report that the last 3 years they were not invited to participate in a product offered by an insurer with which they were already participating. Most recently, hundreds of physicians were dropped from Emblem's network based upon what Emblem described as a physician's failure to transition to value-based payment, despite having little, if any, advanced warning that this requirement was going to be imposed on them. Therefore, in addition to continuing to press for an investigation into the adequacy of their network, MSNY is urging that state legislators enact Assemblyman Levine and Senator Hannon's legislation that passed the Assembly last year to provide physicians with necessary due process protection when health insurers terminate a physician from the network by failing to renew a contract. Equally important is passage of legislation to assure that any physician who is willing and able to meet the terms of an insurer's participation contract will have that opportunity. Another concern we have is inadequate directories. Our survey, 45% of responding physicians report they are inappropriately listed as participating physicians in a health insurer's website in the last year. We have repeatedly raised the concern to state officials that such inaccuracies could mask what is in reality an inadequate physician network, and we are hopeful that efforts are underway to address this problem. Exacerbating the problem of smaller physician networks is the fact that patients find they have little option to receive care from physicians out of network. Over 33% of physicians responding to MSNY's survey indicated that the number of patients they treat with out-of-network coverage has declined significantly in the last 3 years, and 42% noted that their patients with out-of-network coverage have less coverage than 3 years ago. A recent enrollment report by the New York State of Health showed that out-of-network coverage options were only available in 11 counties in New York State, and shockingly, none in the New York City area. This is grossly unfair to patients with chronic illness who have relied upon paying for coverage options to be treated by the physician of their choice. We strongly urge the legislature to pass a law to require out-of-network coverage in the exchange. Now, perhaps nearest and dearest to me and the greatest concern, even if a patient has comprehensive coverage, is they still may not receive treatment and medications they need because of burdensome hassles associated with receiving this care. Another MSNY survey showed that 90% of physicians report that insurers fail first protocols for prescription medications sometimes adversely affect patients, and 45% indicated they frequently adversely affected patients. In another MISNY survey, 83% of respondents indicated that the time they spend obtaining authorizations for health insurance from health insurers for needed patient care has increased in the last 3 years, and nearly 60% indicated it increased significantly. At the same time, a study by the Robert Wood Johnson Foundation shows that physician support staff spend nearly 20 hours per week on interactions with health plans, and a just-released Medscape report concluded that in 2015, 54% of self-employed physicians and 59% of employed physicians spent at least 10 hours per week on paperwork, as compared to 35% of employed and 26% of self-employed physicians in 2014. Now, we at MISNY have supported a number of reforms listed in our written testimony to reduce the prior authorization hassles, including legislation sponsored by Assemblyman Gottfried, to assure same specialty review of medical necessity determinations, and permitting physicians to more easily override a health plan fail-first prescription protocol. Of course, insurers can impose these hassles because of their substantial market power. Regional markets continue to be dominated by a small number of health insurance behemoths. According to a 2015 report from the American Medical Association, 87% of enrollees in commercial managed care products in New York State are enrolled with just 6 health insurance companies. And this lack of competition will grow worse if Empire's parent Anthem is permitted to merge with Cigna, and Aetna is permitted to acquire Humana. We have urged the Department of Financial Services and the Attorney General to reject these mergers, as have other consumer and labor groups. And we have been working with the AMA and other state medical societies as we have brought similar concerns to the Federal Department of Justice. Because of this overwhelming market power, physicians are often in no position to push back against an array of hassles that stand in the way of patients receiving the care they need. Therefore, we need legislation sponsored by Assemblyman Gottfried and co-sponsored by many members of this committee that permit independently practicing physicians to collectively negotiate patient care terms in these market-dominated companies. We greatly appreciate your efforts to determine what additional mandated coverage should be, and we remain very concerned that efforts to address coverage gaps can be undermined by huge cost-sharing burdens, narrow networks, zero out-of-network coverage, and the overly burdensome administrative barriers. Thank you for your attention to these concerns. We look forward to further discussion to addressing them.
Thank you, Dr. Sellers. Mr. Oster, do you have anything to add?
No, we're happy to answer any questions that you may have.
Thank you. Dr. Sellers, thank you for your testimony. It was far-ranging and not on point mostly, but that's okay. We only get to ask the questions. We don't get to pick the answers. But I would like to summarize it for the purposes of this hearing. This is not a hearing about all manner of issues pertaining to health insurance companies, including network and co-insurance charges and all the other matters that you raised. It is about the essential health benefits cap and how we implement any changes that we think are appropriate to that cap in a way that is consistent with federal law and a way that accomplishes it in the most efficient means possible. If I could just understand your testimony is, yeah, essential health benefits cap, it's everything else we care about. Is that kind of it? Because that's what I got from your testimony.
Okay, let me, maybe if I can restate.
Okay.
So again, we do have gaps in our essential benefits.
Okay.
And some of those gaps are for testing that is mandated now for particularly primary care physicians in the state, such as hepatitis C, HIV, autism screening, and follow-up of dense breast tissue on mammograms. Right. 4 mandates from the state. If we are mandated to address these issues, we need to have them mandated to be covered. Okay. The other thing, though, the bigger thing in the daily practice of medicine in this state is that insurance hassles imposed on the patients, imposed on the providers.
I understand, and you have a wonderful representative who makes these points almost on a daily basis with us in Albany. That is not the purpose of this hearing. Okay. And all due respect, and I really do appreciate and respect what you do, and I don't disagree with a lot of what you said. It's just not what we're here for. Okay. So if you have anything else on this point, I'd love to hear it. And Mr. Oster, do you have anything?
I would just